Okay, thank you very much, Sahar. So I'll keep this relatively low tech. No laser or light-based devices used for this. So I'm from the States and have a particular interest in periocular rejuvenation. We'll talk about both synthetic fillers. In the second half, I'll talk about fat used for the same end goals, really, but obviously different modalities. Everybody hear me okay? I can't tell if this is loud enough. Okay. So disclosures, I've worked with Allergan, Galderma, and Mertz. So if we're looking to achieve a beautiful periorbital area, it helps to start with what we can hopefully agree is what a beautiful result is. And in this well-known actress, we can see nice highlights around the eye, both in the superior periorbital area and inferior periorbital area on the left side. And then on the right side, you can see that as she ages, she begins to get hollowing. It starts in the medial aspect in both the upper and lower eyelid areas, and then advances more laterally. So you begin to see tear trough formation initially medially, and then you get more lateral infraorbital exposure of the rim. Same thing happens, it appears, in the superior periorbital area, where the hollowing seems to appear in most people initially medially. Another representation, split face example, obviously hollowing medially for the superior periorbital area and also inferiorly. And interestingly, not much descent to the brow, but that's a subject for another talk. You can see, of course, pseudoherniation of the lower eyelid, one thing that's been covered by several speakers already, so I won't belabor that, but obviously that creates a contour excess under which you get more hollowing or more shadow effect, sort of like a valley that doesn't get light cast into it, over which a shadow is cast from the hill up above it. Anyway, so filling that valley can help to improve a nice smooth contour that we see in youth above. What also, of course, happens is bony atrophy, which causes radial expansion of the orbit and further hollowing. And as we follow someone through the ages, you can see that just creates more of a hollowed out appearance. And if we only do a brow lift for this, then we just elevate the brow and we don't really rejuvenate the upper periorbital area. She just has complete exposure of her upper eyelid, and that's not a youthful rejuvenation. What is a youthful brow? What's the height of the brow above the lid? I kind of think of the palpebral height, or the eyelid opening height. And you can see in this baby, as far as ratios go, it's no higher, the brow is no higher than that height above the upper eyelid sulcus. So just something useful to keep in mind. Again, what's a youthful brow? Is it necessarily arching? Obviously, this mother-daughter combo, the daughter, the younger patient, or younger person, actually has a more downsloping brow. You could argue that the mother's is more aesthetically pleasing, but both of them have nice highlights beneath the brow, and neither of them is as elevated as the older patient or the older individual we saw just a second ago. So if we do correct, and I did artificially for everyone here, the shadows that we see there, so these shadows here, if you go then to this side where we've corrected these artificially, I think that creates a little more youthful periorbital area. This is our patient. The previous one wasn't, of course, but this was actually a patient in a study that we published in PRS, but with no surgery at all, just a little HA filler, we're able to, I think, pretty well efface the lower eyelid hollow, not just medially, but extending a little more laterally. She did come back later and do an upper blepharoplasty, but she actually had pretty good retention of her upper periorbital highlight, a little bit of medial atrophy there.
This is after blepharoplasty.
This is before blepharoplasty. This is no blepharoplasty. Yeah. You can achieve, in many cases, as good and sometimes better results with this than you can with blepharoplasty. So she's in an article we published in PRS, which just showed long-term maintenance of effect. In this case, long-term was 14 and a half months or so. 85% of the effect seemed to be retained at that point. I can tell you I have it beneath my own eyes, and I've had 6.5 years I had it before I had a touch-up. And at that point, we did 3D imaging, which showed that there was still some retained effect. So it does last quite a while. It's now been about 10 years since I initially had it injected. So it does last quite a while. There's another one of our patients, and I apologize for the color, it's a little darker, but I do like to use photos, at least one of the photos, maybe on direct view, without a flash. And I think that allows you to really see the hollows. I don't know if anybody's mentioned that already, but I instruct my staff to make sure we get at least one photo without flash so we can see the hollows and shadows a little bit better. If you don't do that, you're going to rob yourself afterwards of being able to demonstrate to both yourself and the patient the full effect of what you've achieved. So she has a decent highlight around the eyes, and because we're not using a direct flash, I'll show you with a direct flash in just a minute what the difference is, but decent highlights around the eye. And so she probably looks like she's, I would say, in her 40s or maybe 30s. But in actuality, she's in her 50s, and that was actually after we had done filling. So this is before, and you can see the hollowing of and exposure of the upper eyelid area, as well as some hollowing in the infraorbital region. Apologize for the marks that are on there in preparation for filling, but and there's a little bit of swelling that occurs with the topical that we use, but nonetheless, she had an improvement on her right side of the hollows, and it almost, when you look at her left side, so the right side of the screen, then it almost looks sort of more tired, sad, or certainly aged relative to the right, and overall, I think more attractive when there's more highlight around the eye. I do like to use cannulas. I know that 22 gauge and higher is thought to be less likely to cause embolism. Knowing where the vessels are and injecting only in withdrawal, we tend to use a 27 gauge just for precision in the periorbital area, and then I use 25 or larger in the rest of the face. Typical injection sites, even in a patient young like this, will typically start about at the mid-pupillary line, below the tear trough, so maybe just above the high point of the nose there. Most of it can, in my hands, can be accessed by that access point. What we can't quite address, I'll then come laterally, just outside the lateral canthus there, for the lateral infraorbital rim. And then sometimes there's just one little area right at the transition between, in the medial aspect, right at the transition between where you filled from that inferior access point and what you can achieve from the lateral access point that can't quite be smoothed out perfectly. And so I'll go actually through the malar mound then, which is, of course, right in this area here, and fill from that approach. It seems to direct you with a cannula, which I pretty much exclusively use in this area. It seems to direct you into a more superficial area where you can then just put a small amount in there to smooth out that last transition area. Just be aware that when you do that, there is increased risk of Tyndall effect, of course, in that area, even with some of the fillers that are thought to be monophasic and therefore less likely to cause Tyndall effect. I've seen it with all fillers. So.
Sorry, can you just put the pointer to where you go in?
Sure. So we'll start here. We'll go laterally, just beyond the lateral canthus, and then here's the malar mound, bounded by these ligaments here. So right here. Maybe I'll show you again on a patient with better example of the ligamental depressions. So this slide is just to make sure that we're aware of where we put the, measure how far out to put the insertion site, so we see where the tip of the cannula is going to go, and measure back to where your needle is going to insert. So that was all infraorbital. Go back. And so then upper lid, I'll find another one where I can see the ligaments better. But upper lid then, this is immediately after her right upper lid. Of course, the patient I showed you earlier, she had her upper periorbital area filled as well. But this patient just had her superior periorbital area filled. The access points for these would be lateral canthus right about here, and then probably about at the mid-pupillary line, sort of vertical line straight up from there to access the more medial part. And immediately afterwards, so obviously a little bit of swelling, but you can see that her upper lid is less visible. And my mentors, the Glasgolds, will call this a double parallel line that you're looking to achieve, representing the upper lid line and the reflection of the subbrow skin. So you can see there's more upper lid show, pretarsal upper lid show on the patient's left side that was not treated yet in this photo, and more hollowing there, and so that the lines aren't exactly parallel or are less so on that left side. I was going to show you her post-op day one where she's less swollen. Where she's a little bit swollen, but it's not excessively so. We're going to talk a little bit about temporal filling, blending that in. Not crucial to show that. My thoughts on temporal filling are basically, I used to do it all subcutaneous via a cannula. If you just restart the computer. Restart the computer maybe? Okay. Via cannula approach subcutaneously, and I was pleased with that, but there's more. Obviously, there are lots of superficial veins in that area, so I switched to even with the cannula, so you can get bruising, of course. And so I switched to a deeper injection with needle down on periosteum, and it's just safer, it's quicker, and yes, I know you use more product, but patients don't like to be bruised. What's downtime worth to them? In many cases, they'd much rather have a little more expense than a week or two of bruising. Of course, bruising could take 2 weeks if you don't treat it with V-beam or something else. So, and then I was going to summarize the fillers. Basically, I think they're a great starting point for anybody who hasn't filled in this area before. They're reversible, of course, with hyaluronidase. You only want to inject on withdrawal. I prefer cannulas for the reasons I mentioned. And note that, at least in the U.S., they're not approved for it. They're off-label in the periorbital area. Not sure about other countries. Inject only on withdrawal. Make sure you know where I didn't go into detail about where the vascular foramina are, but make sure you're familiar particularly with the infraorbital, supratrochlear, and supraorbital foramina. And then you can blend it into the cheeks and temples. And then I think we're coming here. So then I was going to talk about fat transfer, and my thoughts on fat transfer. Basically, you can achieve very similar results with fat that you can with fillers. Of course, there's more downtime. I tell patients frequently 2 weeks as opposed to 2 days with synthetic fillers in this area. But it can be a little bit longer. It can be less than that. But there's also a more durable effect. And it's natural stuff. There's no chance of a Tyndall effect. So for many patients, that's preferable. A lot of times I'm doing surgical procedures such as facelifting or blepharoplasty, and so it's not as big of a hurdle for them. But I will do fat as a standalone procedure. The equipment's inexpensive. You can achieve everything with probably $1,500 US or less. And so it's about the best return on investment that I've ever had in practice. Key things for me as far as the technique and harvest methods and processing methods are debated, but essentially delicate handling, particularly on withdrawal or aspiration of the fat from the belly, waist, or thighs. So no more than 2 cc's of back traction on a 10 cc syringe will help to minimize chance of trauma to the fat and preserve viability of the fat cells. And then inject after I actually do centrifugation for 3 minutes at 3,000 RPMs. And then transfer it to 1 cc syringes, inject with only 0.9 and 1 or 1.2 cannulas, and carefully, methodically, in multiple planes with multiple passes in order to achieve the desired effect. And I measured it once. I probably only do 5 or 7 passes per 0.1 cc when I'm injecting. So it's pretty slow. I think we're almost up here. Fat transfer versus fillers. Thanks for your patience on that. Because one of the advantages of fat is that it's long-lasting. The disadvantage is that if you mess up, then it's going to be there for a long time and hard to get rid of. So always underfill. A couple technical points about injection of fat. It's very similar to synthetic fillers, but we tend to achieve all of the injection of the infraorbital rim from this inferior access point with fat. Just tends to work well. In particular, you don't want to use the lateral access point. My mentors found that you could get actually a little bit of a roll of fat along the infraorbital rim that you don't want if you try to access the infraorbital rim from the lateral aspect for fat. Not true for synthetic fillers. Probably just more swelling associated with fat, but at any rate, if you're going to do this, then try to address it all from the infraorbital rim. Conversely, the anterior cheek you want to address from laterally. So it's probably because of the orbicularis retaining ligament, tear trough ligament, but nonetheless, just a little pearl. This is just a typical markup of how we address the areas, very similar to synthetic fillers. I don't inject right here in the pretarsal lid. That's just for blepharoplasty marking. In the supraorbital rim, mostly, again, just like with the synthetic fillers, 1 access point in the lateral canthal area. I think you can almost see it right here. She's had an upper blepharoplasty, so there's suture coming out of there, but and then 1 at about mid-pupillary line, so about here. So about here and about here are the 2 access points for the upper lid. Don't need to belabor that. So then just some examples of what I was happy to achieve in patients with mild, moderate, and then more advanced atrophy. Many of them are in conjunction with surgical procedures. So she had a deep plane facelift and neck lift together with fat transfer. She had no blepharoplasty. I'll try to tell you the ones which had blepharoplasty, but 3 cc's is pretty typical in the infraorbital rim, and then I blended it into the anterior cheeks and lateral cheek and lateral canthus. And I like the 3/4 view because you can see the opposite cheek better. Again, no blepharoplasty. So by filling that valley in the anterior cheek, we're able to bring that sort of lifting the tide up to cover that valley. Patient a little further along the atrophy spectrum, and we had to use a little bit more for her, 3 cc's infraorbitally, 2 on the supraorbital rim. She did have an upper blepharoplasty as well, but nonetheless some improvement of the highlight both above and below the eye, and blended it with the anterior and lateral cheeks. And then a patient with more advanced atrophy, and this is kind of pushing the limits of what you might be able to achieve, I think, but 4 cc's in the supraorbital rim region and 4 along the infraorbital rim region. And so I think that decently effaced the upper lid pretarsal skin show, and created a better approximation of those double parallel lines that we're trying to achieve. But I like to look at this one and think, would I now want to do a brow lift on her? And if somebody might have thought that before, then hopefully they wouldn't at this point, because I think there's plenty of distance between the lid and the brow there. So, and then males, just essentially be more conservative. While I did similar amounts along the inferorbital rim, I did nothing in his anterior and lateral cheeks. He did have a lower blepharoplasty as well to get rid of some of that fullness, but nonetheless, very conservative is the key point. In this gentleman, we did do a little bit in the anterior and lateral cheek, but a third as much as we would have done at a starting point for women. So much more conservative in guys to prevent that unnatural femininized appearance. And so enhancements for the future, we've begun using PRP in all of our fat transfer, and I've been encouraged by the early results. It's been almost a year, and I've been mixing in about 1 cc of PRP to 9 cc's of fat, and I think there's a trend toward decreased downtime and improved retention, but I'll run the numbers subsequently and try to document that. But at either rate, it's not turbocharged the effect. I'm not seeing excessive results or excessive fullness as a result. And that's one of the things I was concerned about. So do stem cells play a role? An animal model has shown increased dermal thickness through new collagen formation in the skin under which fat was placed. And so that may account in part for some of the improvement in skin quality that those of us see that do a lot of fat transfer at probably about a year or so. I don't have any experience with the nanofat, but it seems that even without viable fat cells, you may get some improvement. So whether that's through stem cell effect or not, we'll see. It's still early. And fillers, of course, more specialization will lead to better results. So in summary, volume loss occurs. If you treat it, your patients will be happy, and you will too. Thank you.
Please.